Welcome to session 2 of RIO, Rhythm Interventions Online with a U.S. focus. I'm Dr. Brad Knight from Chicago, and I am delighted to be chairing the next 5 sessions. I want to thank Debbie Nair for the opportunity to help chair these sessions with her today. I'm very excited about the next 5 sessions. We will be discussing and hearing about 4 new pulse field ablation technologies, and because 2 of the cases are concomitant, we will be hearing about 3 new left atrial appendage closure cases, partly with concomitant procedures. I want to thank Radcliffe for the impressive program that they put together. First up, the session is entitled Over-the-Wire Pulse Field Ablation Loop Catheter with a Concomitant Left Atrial Appendage Closure Procedure. For this session, we have a recorded case, and I want to welcome our first case operator, Dr. Usman Siddiqui from Florida Cardiology in Orlando. Alongside Usman, we are joined by 2 expert panelists, Dr. Nitesh Sood from Boston and Dr. Andrea Natale from Austin. So welcome, thank you for joining us. Without any further delay, I'd like to hand this over to Usman to present your case. Thank you.
Thank you so much, Dr. Knight. Thank you, Rhythm Interventions, and for this opportunity. So it is a live case outlining an over-the-wire PFA system along with concomitant left atrial appendage occlusion. These are my relevant disclosures. The overall agenda, we'll be talking about some of the technology considerations. We have a pre-recorded case for you, 0 fluoroscopy workflow, 0 exchange with a FlexCath cross, and then left atrial appendage occlusion, and this opportunity to show a dual seal closure. And then following that, we'll take a break between the 2, do a discussion after the PVI procedure, and then a discussion after the left atrial appendage occlusion. So a background on Pulse Select Pulse Field Ablation System. There are 9 electrodes built to sense ablated pace. There's a 25 millimeter diameter loop. And what I love about this is there's a 20 degree forward tilt, which actually helps get better contact, stable contact, and understand the contact as you're moving around. There's a 9 French shaft, so a smaller system with easy to maneuver around sheath. And it's a 0.032 over-the-wire technique. There is some safety parameters with R-wave gating, test pulse for detection of phrenic nerve, and pretty small system. So this is how it looks like. It's able to give it a fixed electrode spacing. You're able to produce a predictable, consistent lesion. And then over-the-wire technique, which all of us are quite used to, helps us get the stability that we need. The 20 degree forward tilt, I'll show you some examples to ensure consistent contact. The lesion depth, as we all know and learning more and more, is maximized with direct tissue contact. So electrodes 4, 5, 6 are the ones which are in maximum contact, and we tend to tag those on our map, as you heard previously in one of the other talks. And then that helps us maintain contact when repositioning. And the electrode 5 tends to have the furthermost reach. The FlexCath cross transeptal system makes it a 0 exchange system. This dilator, needle, and wire system with RF capability is able to fit the sheath. It conforms to any sheath curve. And since the deflectable sheath is quite robust, we're able to deflect this to get inferior sticks as needed. And the sheath itself is becoming one of my favorite sheaths to go to, where it's a very smooth sheath dilator transition as you go transeptal across. One of the problems that we had with the pre-existing sheaths in the market, valve and port assembly, and the responsiveness of the sheath as you move the curve around is actually very good and 1-to-1, and it tends to maintain the shape once you have reached the area. The catheter itself comes in 2 lengths, 20 millimeter and 13 millimeter, and you can deflect in both directions. However, I tend to use the sheath a lot because that's been our workflow forever for RF. So most of the motions you'll see me doing the case are through the sheath. Preferential ablation ablates cardiac tissue, as we all know. Risk of PV stenosis is really low. Field-based ablation, contiguous lesion, transmural in the shape, just because of the constant distance between the electrode, it tends to get more contiguous lesions and allows PVI in an easy way. Some of the things we don't have to worry about as much. We haven't seen any vasospasm, vagal response with this. Don't have to give any hypertension, any phenylephrine for hypertension. In all the cases that we've seen, I've never had to load any patient, and no kidney-related injury. Following that, we'll be talking about the dual seal closure. In this case, we chose a left atrial appendage occlusion with Amulet with a low vented system, and we'll go over that as well. All right, so let's jump on to the case. This is an 84-year-old female, recurrent paroxysmal atrial fibrillation, failed sotalol, known coronary artery disease, preserved ejection fraction, diabetic, high CHADS VASc, recent GI bleed on Xarelto. So this was our opportunity to offer her a concomitant procedure. And this was one of the first few cases we did originally in our center. These are the baseline TE pictures. We don't pre-image. I know some people would like to see a CT. We didn't have an opportunity to do that in this particular patient. But just to assess the appendage, there were no clots in there. And it looks like a shallow appendage with measurements as shown above. Just to get an idea of how the TE looks. And with that, we'll jump on to the video. Typically, as you can see, most of my workflow is fluoroless until I'm ready to do stuff. We advanced the ice. In this case, we did end up using a 3D ice, which is a Nevera. You place the ice in the right atrium, check the left atrial appendage real quick. So we sized it there as well. We did the posterior tilt, so you can see the SVC. We advanced our wire over the S3C. As you can see my wire here. Following that, I'm going to advance my sheath and dilator. And then we'll slowly pull the wire back, drop the whole system down. Now, this is an important part of the procedure. This is where I love this system a lot. You can actually deflect the sheath to go as inferior as possible. So even if you're dealing with large atrium or right atrium or left atrium, you're able to get a really inferior stick. I try to use my ice to identify and line myself to the left atrial appendage. You can see that I'm heading right at the ridge. So that will give me a good balance between doing my PFA and doing the concomitant as well. I'll advance the wire. Wire goes directly into the appendage, as you can see. So it looks like a really good stick. So I'll dilate and move across. Following this, I'll put my CS up. In this system, we decided to use the cardo mapping system. This is the CS going in, again, fluoroless. Then we'll advance our wire into the superior vein and then advance our sheath and dilator in, as you can see. Again, this transeptal was through the flex cross. I don't know if you noticed, there was a little needle which came out and then the wire advanced through it. I didn't have to use RF. Then we tried to get our ice catheter into the left atrium using the wire as the rail. Typically, I do it as with ice only. I just showed a fluoro picture of how it would line up just for learning purposes. This is how we line the ice into the LA, and I leave it in the mid LA where I can see the mitral valve and the left atrial appendage and the pulmonary veins. Following this, I'm going to create a quick map. I do still believe in high definition mapping. You can map using the Pulse Select catheter. But it gives me much more information of the level of isolation. It gives me information about my contact. So in this case, I'm using an octarray to map. Especially I didn't have a CT. I wanted to understand this left atrial geometry. I don't have the recording system in here, so we're going to use the cardo system in there just so we can focus on the electrograms. This is the right superior vein. You can see big veins with branches. And a very prominent antrum, as you can see on the left side, kind of bulges out. It is a paroxysmal case. My goal over here was to just do PVI, but I'll try to incorporate as much of this broad antrum on the left side that you see. This is the ridge. We like to identify the ridge between the pulmonary veins and the left atrial appendage. And the octarray catheter helps us identify that ridge because some of the catheter is falling into the left atrial appendage. We tag that ridge and make sharp tags and make sure that that ridge is well identified because that's the level of most reconnections. Following this, right now you can see the catheter sitting in the towards the valve appendage and then the anterior wall. You can see most of the voltage looks pretty normal. Now, if I had found abnormal voltage during sinus rhythm, I would have probably tailored my ablation a little bit, like a BIFA approach, where I would have probably tried to do maybe posterior wall, try to take some of the septum out and target some of those areas. But in this case, I didn't deem it necessary. We identify these inferior ridges as well as you're coming out from these veins to identify. And the way we do that is you use your sheath and deflect down as the catheter flies out. We know where the ridge is. Then we identify the lower posterior wall as well. So once this map is done, the next step we will do, which you'll see shortly, is put the wire back in as the mapper is cleaning up this map, and then we'll introduce our Pulse Select system in here. As you can see my ice, I'll spend a minute over the ice. Then my ice is sitting in the right atrium. In the left atrium in the middle portion. And now you can see that my Pulse Select catheter is actually entering. The CW that you see is actually the wire. I have put an electrode on the tip of the wire. So as the catheter goes in, now on CARTA system, it looks like a semicircle, like a horseshoe, which may not be the accurate representation, but it works for this mapping system. The CW is the wire. I've parked the wire in the left inferior pulmonary vein at this time. And you can see on ice as well that my wire is in there. I would like to start. You can see the sharp electrograms. That's one of the things that I love about this system, that the electrograms don't get distorted as much, even with application. Here I start with the inferior. The 5 and 6 are pointing inferiorly, so I'm hitting the inferior part. You can see as soon as I get therapy, the electrograms go away completely. If there's any residual left, I will give another lesion. Otherwise, I would move on. Then I rotate it around, and now it's a little anterior. Just to orient you a little bit, the main view is the PA view, and the other view is the top-down view. The top-down view basically tells me how anterior and posterior I am, and the PA view shows me right and left. I'm moving my catheter, rotating the catheter around, using my intracardiac echo to navigate that. I want to show you this on the intracardiac echo. You can see that I have two views because I'm using the Novera system it is a two dimensions that I'm using in it. So you have a 45 and a 135. So you can actually see the catheter touching in there on both views. Then I do this anchor technique over here. My wire is still in the inferior vein, but I'm using that anchor to actually hit the roof. So that gives me maximum contact over here. So a wire doesn't necessarily need to go into the superior vein for this. If you take the catheter out and rotate a little bit, you may be able to get enough contact on there. And the way I identify contact is, again, looking at the eyes. As you can see right now, it's touching the roof on both views of the ice as well as the map, and you can see the electrograms disappearing as well. Following that, I will rotate the catheter around more. So right now I'm hitting the roof of the left atrium. I look around for signals to see if there's any weak areas over here. And you can see the catheter shape changes a little bit. There's a little fluoro picture that I'm showing as well, where you can see that I'm advancing the sheet to actually get maximum contact. Here I'm looking at the posterior wall. I see a little sharp signal there on the posterior wall at the posterior entrance. I gave one therapy over there before I rotated the catheter, and now I'm hitting the anterior ridge. On the top-down view, you can see that my 5 and 6 are actually anterior, pointing towards the ridge between the pulmonary vein. So I'm giving an application there, and then I'm rotating around my 5 or 6 as the mapper moves around. And to confirm it, now I'm in front of the left inferior pulmonary vein, hitting that ridge. The wire is still anchored deep into the left inferior pulmonary vein. And you can see on ice as well. You can see the ridge very clearly in both views of the ice. That my catheter has very good contact on both the ridge as well as the top part of the ridge. So I look for signals over here just to be sure. These are areas which I tend to give extra lesions because this tends to connect a lot. And I will tend to move. One of the beauty of this catheter is that if you leave the anchor in and you slowly pull it out and counter it, you can give wider lesions. So that's what I try to do. I do a little bit inside lesions on the anterior ridge, and then I turn it out to give inferior. Now I'm parking the wire in the superior vein because most of my anchoring lesions from the inferior veins are done. And in the when parking the superior vein, I'm rotating my catheter around. Right now, I want to hit that antrum, which is wide. So this is how we do the posterior wall too. If you want to do this, you slowly pull the catheter out and clock it towards the right side veins. but leaving the wire inside. And this makes it really easy. You can see the signals over here. They're sharp. The contact on the map looks very good. And on ice, you can see my catheter is outside the vein completely and touching that antrum. So I try to hit the antrum over here to incorporate all that wide area where some of the triggers for AF can be. I'm rotating it around, leaving the wire in there, trying to go back into my area. And I see some sharp signal here. So this is one of the advantages of this system. You see that the whole electrograms don't go away if you didn't have a good lesion. So you can go back and check it in that area. And then once I find that area, I would probably give one more lesion here just to be sure. And that's where I'm doing that other lesion. This is what the carina connections typically can happen. Sometimes you may have complete isolation outside, but there may be some fibers running epicardially and then attaching the carina. So you want to check all that area before calling it the end of the day. So here again, I'll put the wire back in the inferior, and then I'm checking the inferior part of it. And making sure there are no sharp electrograms. Here I find a little sharp electrogram towards the posterior antrum, much wider outside the vein. So I'm going to give one more lesion here to make sure those electrograms, and you can see the immediate reduction in electrograms. So some beauty of electrophysiology is still left in this that we can actually use to give more durable lesion sets. Here I'm moving around to the inferior, moving 5 and 6 inferior, just completely making sure that all areas quiet. Now I'm at the anterior ridge. I see far field. Everything looks far field over there. But just to be sure, I'm giving one more lesion set at the anterior inferior ridge. Following this, I'm pretty happy with this. So I'm going to move on to I don't need to check the veins. I look pretty good. I want to check it towards the end. I move to the right. That's an easy movement on the ice catheter. You just clock it and you can see the beautiful contact on ice in both views. So you have biplanar view on that. And you see the contact on the antrum. First, I would like to go a little ostial, give an ostial lesion, then we come out. Now my 5 and 6 are pointing posteriorly, so I'm getting maximum contact there. My mapper, as he sees sharp signals, he'll shave off some of the map to make it more correlate with the intracardiac echo. You can see here I'm touching the roof of the superior vein, so I gave lesions here, and he'll shave off, and the electrograms go away right away. Then I'm rotating around, and then I've come anteriorly. And you can see on the top-down view, I'm pointing more anterior as well. And then you can see on the ice as well, my contact is good. Wire is still deep in. And then I give one more lesion here to eradicate the electrograms here. So you can see these, if your contact is good and that even if the tissue area is quite thick, the electrograms respond very nicely to these lesion sets. Now I want the same concept as we used on the posterior wall, I'm going to do on the anterior wall. If I want to incorporate wide septum, I will park the wire deep in and then move the catheter out anteriorly and put a clock on it. So more like moving towards the left atrial appendage, and I can give wide lesions on the septum as well. This particular patient didn't have too much abnormality on the map anteriorly in the septum, so we decided not to go too wide. I'm giving a wider area on the roof here just to cover that antrum of the vein, and you can see on ice that I'm way outside of the ostium of the vein, and I'm covering this. And so the map seems to be correlating reasonably well to intracardiac echo pictures. The other thing is in cardio system, you have to turn the magnet off while giving therapy. So that does slow you by a few seconds down, but the stability of the catheter remains pretty good. As you can see, there's been no shift in the map in this particular case. Leaving the wire in the vein, now I'm heading towards the carina. And then now I park the wire in the right inferior vein. I move my ice around really quickly. And you can see now I'm sitting at the antrum. There's, of course, interpolation of the map that you can see, and she's shaving it off to clean this up. I'm very happy with the contact over here. I'm touching the carina here, and my electrograms are sharp and really good. So I'm happy. So I give a lesion, an immediate reduction in electrograms that you can see, just to the area where the electrodes are touching. Then I'm going to rotate it around if I'm happy. If I see the tissue to be really thick on ice, I will give another lesion. Otherwise, I would move. So there's a slight tilt towards the vein, and then I see some electrograms. I give additional lesion. Then I'm rotating the 5 and 6 around to go around the veins as indicated. At all points during the map, the 5 and 6 are highlighted for me. so I can understand where my maximum contact is. Maximum contact doesn't mean that other areas are not touching, but those are the areas which I know that I've hit really hard. So I move around to make sure that all the areas have, the 5 and 6 had touched around the veins completely. This, I'm a little bit inside the vein, just intentionally to see there's no sharp electrograms, there's no muscle sleeves that are attaching. That can happen with the right inferior pulmonary veins, especially from right atrium direct connections. I didn't see any sharp muscle sleeves, but I gave some lesions here to make sure that there's no sharp signals out there. I'm going to give an additional lesion sets inferiorly as I'm moving the catheter around. My 3D ICE person is actually giving me a 3D picture, and you can see how beautiful it looks on the right inferior pulmonary vein. You're sitting right at the ostium. All the electrogram, all the poles are actually touching the walls of the LA. So something which you can use very well to confirm your contact as well. Here you can see I'm trying to give a little wider lesion on the septum. And then this already looks like the electrograms are kind of gone over there. So I may not give a lesion here, depending on what I find. I'm leaving the wire in there. I'm trying to pull out to make sure that I get kind of a double line on the septum as I'm moving out. ICE clearly demonstrates that if I want to go even wider on the septum, I will leave it and then clog the whole system. And in my case, I used a sheath. You can see on fluoroscopy how close the sheath is to the catheter. A lot of operators just use the catheter. The maneuverability of the catheter is fantastic too. But for me, maximum position happens when the sheath is really snugging against the catheter. And this sheath is extremely responsive and gives us this kind of contact that you're seeing on ICE. Thus leading to, of course, first pass isolation. Here I'm giving an additional lesion on the carina. You're still using the anchor on the right superior pulmonary vein, trying to get more wider area around the vein. Since the electrograms were sharp, the maps were corrected to that. And again, now the wire is in the inferior vein, and I'm additionally giving lesions in the posterior antrum. At all times, my 3D sonographer with the ICE is showing me 3D pictures, which I'm looking at it at the same time, along with a map to make sure I have good contact with the walls. And you can see there's one part of the catheter which has maximum contact, and the other part has minimum contact. But in most cases, there's very little space which is free to the blood volume. So that's why I think in their data, they haven't seen too much hemolysis in these, even though you can see the number of lesions I'm applying at quite a few. Once I'm done with this, I'll pull my catheter out and then go back with my remapping. Of course, can you do the remapping with the same catheter? Yes. In this case, we did have an octa-RIO open, so we just wanted to make absolutely sure that we don't miss anything. You can look at the electrograms. There's nothing there right on the cardio mapping system and the smaller window. Now we would pace here as well. You can pace from the Pulse Select catheter too, but I'd like to pace from the octa-RIO from all poles to confirm entrance and exit block. I would put it in different areas of the carina, different areas on the roof. One of the things with, of course, octa-RIO is that the splines are bent. You can tell which area is touching and which area is not touching to confirm that you had good contact when taking those, low voltage points and high voltage points. So there's a very little chance of mistakes here. And you can see these veins are really well isolated. I like the level of isolation. This is what I planned for this particular patient. I didn't want to do a posterior wall on her. It looked reasonably okay to me. One can make an argument of doing this, nothing wrong with that. But I did try to incorporate all the abnormal antrum that I saw on my pre-mapping. So once this is done, then I think I'll probably hold there, and as the thing is running out, I'll stop here and then maybe take some questions, have some discussion about this before we move on to the left atrial appendage occlusion part of this. Thank you.
Those are great case. Maybe we can start with Andrea. A lot of issues came up with just the ablation side of this. Any comments?
I think that was a beautiful demonstration of ICE guided. I think for the current device that still don't provide contact force, ICE is incredibly important. Beyond the benefit of being able to do a floorless procedure, but Usman really showed very well how eyes is important to assess contact. The mapping system is not integrated with the catheter, so some of the accuracy is lost there. So really, eyes become a critical component in this procedure. I mean, the only comment I said, usually our data suggests that 80-year-old women, even when they're paroxysmal, tend to require more. So this might be a patient where before causing the impeding, I might consider doing isolation. But I mean, that's probably the only comment. But the procedure was beautiful. I have to say with the...
Isolation of what, Andrea? Of the appendage?
Yes.
Or the posterior wall? What did you mean by that?
Yeah, I was thinking about the appendage before deploying the watch, because once, especially with the device that Usman is planning to use, completely obliterate access to the appendage. So once it's closed, it's very difficult to isolate. So that would be probably something I would consider, specifically because of the age of the patient. But and then
Nitesh, any comments?
Yeah.
Yes, I think this is.
Thank you, Nitesh. Any comments?
Yes, I think it's a great case. Very well done, Usman. Congratulations. A couple of comments that I'll make for the Pulse Select system versus the other systems. I think you showed very nicely that even in a normal size atrium, you're able to keep the lesions fairly to the antrum of the vein. I feel that a lot of times we are isolating the posterior wall in paroxysmals because the channel is extremely narrow. The other nice thing I saw, which I do as well, is when you're isolating or trying to ablate the ridge, a lot of times with a bigger profile system, you end up overlapping the appendage a lot. So unless you're planning on closing the appendage, isolating half of the appendage, at least the anterior portion, while trying to ablate the ridge can be a problematic issue, unless you are obviously doing a concomitant procedure. So I think it's great. And the one last thing I'll say is, as far as the mapping, I do agree that high density mapping is still an important part of these procedures, because with PFA, as long as you're within 4 millimeters of the tissue, you are going to get electrograms that disappear with just one lesion. Those electrograms, if you are not in true contact, will take at least an hour to come back. So there's a lot of stunning that happens with just one PFA lesion, which is why we double up, triple up, depending on what system you're using. One of the nice things about using an impedance-based system, maybe like Abbott, the ESI system, or NSIDE X, which is what we use, is you can shave down the internal dimension or internal sort of contact to 2 millimeters. So unless you are within 2 millimeters of your shell, it will not give you a surface point on your lesion. So that is one advantage. But you are using ice, which is extremely good. Not all of us have this nice ice machine. I wish I did. But unless you are using intra left atrial ice, having an impedance-based system and making the internal sort of dimension to 2 millimeters also is a nice way of making sure you are in good contact with the tissue. But nice case, very well done.
Yeah, that was very nice. Because this is a concomitant case, I'm going to just ask you to respond to a couple of questions about doing it as a concomitant. I see you have TE probe down already. You talked a little bit about how you do your transeptal puncture in concomitant cases. Can you just talk about how the planning for appendage closure at the end changes your pre-procedural imaging, anticoagulation, transeptal imaging, et cetera?
Yeah, sure.
So, make a comment. Actually, what Usman shows is very important. I think it's something that probably mostly electrophysiology appreciate, but the access, when Usman showed the access in the septum facing the appendage, that is extremely important to make the closure device like a very smooth procedure. And I think this is an area where there is a big difference between EP and interventionalist. I think probably because we are used to use ice, we kind of sort of realize that that's an important aspect, but this is a very important part to make everything really smooth. Even I have to say, even for the the pulse field ablation in low and anterior axis help engaging the right inferior. So, but clearly for a concomitant procedure, it is a critical part of the whole procedure.
Yeah, Usman?
Yeah, so a couple comments. Every lab works differently. For us, even though we have the best tools available, sometimes personnel is an issue for us, which means I don't have the liberty of a constant cardiac anesthesiologist or a cardiologist doing my TE post-procedure. So I've tried to take all of this on our own. Some of our patients come from far, and it's difficult for us to get TE, so we tend to just do a peri-procedure imaging, which means I'll do a TE, do some measurements, get an idea, and then do everything intra-procedurally. That's been our practice. We did some publications on this, and I know it's a little different from what most people do. It's been working for us for now, but so that's what I do. As far as other planning is concerned, I think what Dr. Natale mentioned is the key: transeptal puncture. As low as inferior that you can go, I think helps us a lot. In cases where you're doing concomitant, I think guiding your transeptal puncture just to that ridge between the left atrial appendage and the pulmonary vein is the key. So that way you have both access to both. So you can rotate the catheter around to the right veins easily, and at the same time, getting into the left atrial appendage becomes a breeze. So I think that is extremely important. What would CT do different? Yes, they'll probably point you towards the same kind of axis. Can you size the device based on CT before? Yes, possibly. And can you get the device ready to go? It give you an extra confidence, possibly. Yes. So where we have that capability available, we'll use it.
Thank you. In the interest of time, we have about 6 more minutes. Why don't you go ahead and show us the closure part of the case?
Okay. So let's see if the video is still running, or they paused it, I hope. Okay, so let me play this, right? How do I get back to the video?
If we can, that would be great. And did you do anything differently in terms of sizing, because you had just done an ablation? Did you consider edema of the ridge or any further imaging to make those decisions?
Yeah, beautiful question. So yeah, I think we may have to go back. We just should have paused this video while we were doing the discussion. I think that's the intention of this. Yes, go forward a little bit.
There we go.
What we tend to do is, so while they're doing this, I'll tell you real quick that what we tend to do is remeasure using intracardiac echo. At the time, if I have a cardiac anesthesiologist, I will remeasure using the TE. But intracardiac echo typically does well. Then I'll do a left atrial appendage angiogram to confirm my findings. And since I'm using a dual seal technology, a lot of times, a little bit variation in size, I can play with by getting a full closure. So we can move forward a little bit here in the interest of time. Thank you, and a little bit more.
You just do the angiogram with you did the angiogram with the PFA sheath?
Once I exchange the sheath, so in this particular case, I use a deflectable sheath. I'm addicted to deflectable sheaths. So here I am. You can see that I parked my wire in the pulmonary vein. I'm exchanging. This is the Amulet deflectable sheath that I'm using. That also gives me more confidence, because with a deflectable sheath, I can get to any lobe that I would want to. And then also place the lobe in the device where I would like to. So this is my exchange that's happening. So this is the pigtail coming out of it. You can see the axis is really good. I'm going directly into the appendage. So I'm quite happy with it. This is my pigtail in there. So I'll shoot an angiogram here, and I'll do a sizing just to make sure that nothing has changed. So you'll see an angiogram. You'll see some contrast happening here as I'm doing this. You have to take 2 minutes to put your lead back on for this, but this part you do with fluoro, and then I'm parking it in, and you'll see an angiogram coming in shortly. At the same time, while they're doing this, my ice person will actually freeze some ice pictures and measure this. So as I'm doing more and more dual seal, I've actually started moving away from landing zone and moving to where the orifice of the device is. So orifice of the left atrial appendage, because I want my disc to sit outside right where that orifice is. So I will do a measurement right there. So you can see the angiogram, orifice is right there, and then go 1 centimeter in it. So this is the landing zone. And I'll try to keep my disc right outside. You can see the measurements happening. They tend to correlate. In this particular case, they correlated quite well with what we did with the TE. You can see the circ very nicely on that picture. So once I've done this, now I'm advancing my device. You can see the device in here. You see the ball over here. It's past the circ. In my first initial cases, I used to be quite deep. And then the other thing I wanted to point out on ISIS, because I have to do biaxial view in this biplanar view, I'm looking at a 135 and kind of somewhere between 90, because I can see my mitral valve in there. So I'm at a 90 / somewhere between 135 and 180 view. So I'm looking at both views to make sure that I don't have too much shoulder. So I do another angiogram once I'm in the ball to make sure that my ball is past the circ. I have reasonable area for those anchors to settle. Then I would go into the triangle at this point. This is the triangle. You can see that the anchors are attached on both sides, and I've kind of hooked that device in. Now you can see that there's a little bit of shoulder on one of the views. So I just recaptured and put that back in, as you can see. And now on both views, you can see that the device is sitting nicely in. Now, eyes can sometimes fool you on this, on the 135 view. Sometimes you can see that shoulder, so you check with an angiogram, and you can see on the angiogram, my both anchors, which are towards the mid-distal part of this device, are attached. And this is my tension test when I'm deploying the disc. You can see that this sits out beautifully right outside, covering the ridge and not affecting the mitral valve at all. This separation between the lobe and the disc, so which means I have atrial tissue in between, which is going to anchor this device and it's not going to come out. So I don't really need to do a tension test. Following this, I'll do a maximum color over here. I'll bring the scale down and make sure there's no leak around and look at all the views. As you can see, I will also do a contrast injection at this point to confirm that there is no leak around the device. And you can see
Thank you very much. It was a nice case. I think in the interest, Usman, I think I'll have to interrupt you given that the time is running short. Do the panelists have any brief comments about the closure part of the case?
No, it's very good. I think the only thing I would say that, for Amulet, we try to ensure that the appendage and the pulmonary artery are not too close because of the potential risk with the whole system of pulmonary artery tear. But that's really, that was a beautiful deployment. Very good job, Usman.
Yeah.
Thank you, sir.
Yeah, agreed.
Nitesh?
No comments. No, I think the deployment was great.
All right.
Nice case.
Yeah, no, this was great. We could talk a lot about each aspect of your case, but in the interest of time, that brings us to the end of session 2. Thank you very much for the panelists. Outstanding case. Thank you for sharing that with us, and please come back and stay with us. Thank you.